The following podcast is part of a certified educational activity titled From Screening Through Treatment: Proactive Engagement of Patients in Team-Based Care for PPD. Access the entire activity and complete the post-test at peerview.com/BMZ860. Downloadable slides and practice aids are also available.
Hello, I'm Dr. Camille Hoffman, a professor of maternal-fetal medicine at the University of Colorado in the departments of obstetrics and gynecology and psychiatry. I'd like to talk with you about postpartum depression. My talk is entitled From Screening Through Treatment: Proactive Engagement of Patients in Team-Based Care for Postpartum Depression, or PPD. Our goals for today are to increase your understanding of the importance of consistent screening, accurate diagnosis, and prompt treatment of adults with postpartum depression, or PPD. Also, to improve your capacity to use validated screening tools and clinical guidelines to diagnose PPD in the OBGYN setting. We'll enhance your ability to initiate culturally sensitive conversations with patients about PPD management strategies to reduce stigma associated with PPD, and will augment your knowledge of the efficacy, safety, and tolerability of current and emerging treatments for PPD. Finally, our goal is to equip you with strategies for integrating new treatment options into practice to optimize the management of PPD in the context of interdisciplinary team-based care. Seminar 1, Screening Practices and Open Communication for Timely Diagnosis and Engagement of Patients in PPD Care. So first, I want to talk about the prevalence and consequences of postpartum depression. As many of you know, postpartum depression is one of the most common medical complications of pregnancy. Symptoms will occur in over 13% of all live births in the U.S., which is approximately 500,000 women per year. About 70% of women with a pre-existing mood disorder who discontinue antidepressant use in pregnancy will experience a relapse of major depression in the peripartum period, including during the postpartum period. We also know that untreated PPD elevates the risk for the following behaviors in mothers: addiction, relationship difficulties, suicidal ideation and suicide attempts, and a decrease in engagement in parenting behaviors, including parents being less likely to talk to their babies, use car seats, or bring in their children for well-child visits and checkups. In addition, untreated PPD elevates the risk of the following in children who are exposed to perinatal depression and anxiety either in utero or post-birth. And these include sleep disturbances, lower IQ, slower language development, behavioral problems, and a risk of psychiatric illness in themselves. Untreated PPD also elevates the risk for partners and society at large. Partners of patients with PPD experience increased levels of stress, anxiety, and depression themselves. And we know that unresolved PPD imposes a significant economic burden on our healthcare system and our society. In summary, it's a lot of human struggle. OBGYNs and obstetric clinicians in general can play a huge role in the detection and management of PPD. We know that approximately 1/3 of all physicians for women aged 18 to 45 are with an OBGYN. And many women report that their OBGYNs are their main source of routine health care, or their only source of routine health care. Women with symptoms of PPD also identify their OBGYN provider and their obstetrics clinic as their preferred provider for mental health treatment. So the data are strong that our patients prefer integrated models of care or to receive behavioral health care and treatment within the obstetric clinic setting. ACOG recommends that OBGYNs and other obstetric care providers should screen patients twice during the antenatal period for depression and anxiety symptoms using a standard validated tool. ACOG also recommends that OBGYNs complete a full assessment of mood and emotional well-being, including screening for PPD and anxiety with a validated instrument, during the comprehensive postpartum visit for each patient between 4 to 12 weeks post-birth. We should be prepared to initiate medical therapy and/or refer our patients to appropriate behavioral health resources when indicated, and we should have systems in place to ensure follow-up for diagnosis and treatment. A common question that I get from my obstetric care colleagues are, how do we distinguish baby blues from PPD? So the prevalence of baby blues is about 85% of our patients versus 13% of our patients postpartum will have postpartum depression. The onset of baby blues is within a few days after giving birth to typically peaking on the 4th or 5th day and lasting usually no more than 2 weeks. Versus postpartum depression typically emerges between the 3rd trimester of pregnancy and 2 to 3 months postpartum. The duration of baby blues lasts a few hours to a few days and remits spontaneously within 2 weeks of delivery, while postpartum depression lasts longer than 2 weeks and can last up to 3 years. The severity of baby blues is a range of mild symptoms, mood lability, tearfulness, anxiety, and irritability, while postpartum depression is a part of a clinical diagnosis of a major depressive episode. There isn't usually impaired functioning in baby blues, while we know that one of the hallmarks of postpartum depression is impaired functioning. In baby blues, symptoms usually resolve spontaneously, while with postpartum depression, symptoms usually require some form of treatment. And baby blues is unrelated to psychiatric history and not predictive of future problems, including mental health problems, while postpartum depression is more common in women with a history of major depression and bipolar disorder and is also predictive of future depressive episodes. Wanted to review the DSM-5 diagnostic criteria for major depressive disorder with a peripartum onset or postpartum depression with you. 5 or more symptoms need to have been present nearly every day during the same 2-week period and represent a change from previous functioning. And at least one of the symptoms is either 1, a depressed mood, or 2, loss of interest or pleasure, also known as anhedonia. The symptoms must impair functioning and cannot be secondary to any other drug or illness. Other symptoms include significant change in weight or appetite, insomnia or hypersomnia, psychomotor agitation or retardation, fatigue or loss of energy, feelings of worthlessness or excessive or inappropriate guilt, a diminished ability to think or concentrate or indecisiveness, and recurrent thoughts of death, recurrent suicidal ideation without a specific plan, or a suicide attempt or specific plan for committing suicide. The peripartum onset specifier includes an onset of symptoms during pregnancy or within 4 weeks after childbirth, and episodes can present with psychotic features. As recommended by ACOG, OBGYNs should choose a validated screener and use it consistently in their practice. This is an Edinburgh Postnatal Depression Scale, or EPDS, screener. While it's called Postnatal Depression Scale, it's also been validated for use during pregnancy and has also been validated in over 40 languages and is available freely online in multiple places. It's a 10-question questionnaire, and a score of greater than or equal to 10 and or a non-zero response on item 10 should be evaluated. A score greater than or equal to 10 is considered positive, and question number 10 is the self-harm or suicidal ideation question. So whenever we are looking at the EPDS, we should look at the overall score as well as look at the answer on question 10. And if it's anything more than never, do additional questions, which I'll cover in a moment. This is an example of the PHQ-9 or Patient Health Questionnaire 9, which is a 9-question questionnaire that can also be used for screening for depressive symptoms. Of the 9 items, if 5 or more are checked as at least more than half the days, or either item 1 or 2 is checked as at least more than half the days, the screen is likely positive. And like the EPDS, a score of greater than or equal to 10 is considered positive. And a non-zero response on item 9, or the self-harm question, is also considered a positive screen. And then the clinician should proceed with further questions. So when we see a patient respond positively or affirmatively on questions number 10 or question number 9 of the EPDS or PHQ-9 respectively, this does suggest that a patient may be at risk of self-harm or suicide. If this occurs, do not leave the woman alone in the room until further assessment or a treatment plan can be established. You can immediately assess further by asking the following questions. 1, in the past 2 weeks, how often have you thought of hurting yourself? 2, have you ever attempted to hurt yourself in the past? 3, have you thought about how you could harm yourself? If there's any kind of plan of self-harm or harm to others, refer the patient to psychiatric emergency services immediately. Your office can assist in arranging for someone to be with the patient and for transport to an ED or further psychiatric emergency services. However, if there is no plan for the patient to harm herself or others, provide assistance and resources as needed, but you may not need to escalate this to emergency psychiatric services. Things we'd like you to consider if there is no plan to harm oneself or others are to still assess for the patient's social support, engage her social support system as you are able, ask whom can she rely on for childcare or who else can she talk to for support. Also, inform the patient of emergency resources in your local area if depression symptoms worsen or she begins to have thoughts of self-harm or harming others. So these can include local crisis lines, national crisis lines, or hospital emergency departments. And finally, help a patient make a safety plan and arrange to follow up at least by phone in a few hours or days as your scheduling and staff permit, and as the patient is available. In the ACOG recommendations, there's also mention of screening for bipolar disorder. And this is especially important if you are going to start the patient on an SSRI or monotherapy. So this is an example of one existing bipolar disorder screener called the Mood Disorder Questionnaire, or MDQ. A positive screen on the MDQ requires a greater than or equal to 7 yeses on this 13-item questionnaire and more than or equal to 2 co-occurring symptoms. The level of functional impairment must be a moderate to serious problem, as indicated by the patient's answers. Another way to screen for bipolar disorder is called the CD. And this is more of a conversational algorithm that can be asked after you've looked at the EPDS or PHQ-9 results. So the first question asks, some people have periods lasting several days or longer when they feel much more excited and full of energy than usual. Their minds go too fast, they talk a lot, they are very restless or unable to sit still, and they sometimes do things that are unusual for them, such as driving too fast or spending too much money. Have you ever had a period like this lasting several days or longer? Question number 2, have you ever had a period lasting several days or longer when most of the time you were so irritable or grouchy that you started arguments, shouted at people, or hit people? If the patient answers yes to questions 1 or 2, then ask question 3. People who have episodes like this often have changes in their thinking and behavior at the same time, like being more talkative, needing very little sleep, being very restless, going on buying sprees, and behaving in ways they would normally think are inappropriate. Did you ever have any of these changes during your episodes of being excited and full of energy, very irritable, or grouchy. If the patient answers no to question 3, the patient's screen is negative for bipolar disorder, and she may still be eligible for antidepressant medication. On the other hand, if the patient answers yes to all 3 questions, this suggests that that patient might have bipolar disorder, and we recommend more immediate connection to psychiatry and psychiatric care for treatment aside from antidepressant monotherapy, as an antidepressant alone may put the patient at risk to develop manic symptoms. ACOG also recommends screening for anxiety. And one thing that I wanted to mention about the EPDS is that there is an anxiety subscale, traditionally questions 4, 5, and 6 on the EPDS, that have been correlated highly with a positive GAD-7 score. So for those of you who are most familiar with the GAD-7 and use that in your practice, the GAD-7 anxiety severity is calculated by assigning scores of 0, 1, 2, or 3 to the response categories of not at all, several days, more than half the days, and nearly every day. The GAD score ranges from 0 to 21, and a score over or equal to 5 is considered a positive screen. There's also screening for post-traumatic stress disorder that does exist and is available online. On this screen, the PC-PTSD, it asks about things that happen to people that can be unusually or especially frightening, horrible, or traumatic. And then the patient answers no or yes to experiencing various types of traumatic events. If the first item response is no, then the score is 0. If the first item response is yes, then sum the number of yeses for the last 5 questions. A score of greater than or equal to 3 on the PC-PTSD screen is a positive screen for PTSD and also warrants further behavioral health evaluation and care. Then I wanted to talk about assessing for the presence and severity of perinatal mental health conditions. So on the upper left, we have depression, and we've talked about the PHQ-9 and the EPDS. We've talked about bipolar disorder screening, both the MDQ and CD. We've talked about anxiety scoring, either using the GAD-7 or the EPDS anxiety subscale. And we've also talked about PTSD. We've also talked about a positive response to the self-harm question on the EPDS or PHQ-9, and questions and further follow-up depending on the patient's answers. And so I wanted to also give some other information on how we can determine our illness severity, because that's going to also help guide what we recommend for treatment. So things that are considered mild symptom severity are depression screener scores of 10 to 14 on the PHQ-9 and EPDS, a GAD-7 score of 5 to 9, a PC-PTSD 5 score of less than 3, no suicidal ideation, and not feeling helpless or hopeless. In addition, not feeling worthless, no previous psychiatric hospitalizations, and no or minimal difficulty caring for oneself or their baby. Things that become more moderate symptoms are depression score screeners from 15 to 19, GAD-7 scores between 10 and 14, a PC-PTSD score of greater than or equal to 3, some suicidal ideation present, sometimes feeling hopeless, helpless, or worthless, previous psychiatric hospitalizations, or some difficulty caring for oneself or the baby. Factors that would make the illness severity in the severe category include depression screening scores greater than 19, GAD-7 score higher than 15, a PC-PTSD score higher than or equal to 3, any suicidal ideation, intent, and or plan, previous suicide attempts, often or all of the time feeling hopeless, helpless, or worthless, history of multiple psychiatric hospitalizations, The patient often feels unable to care for herself or her baby, or any experience of hallucinations, delusions, other psychotic symptoms that can be congruent with either major depression with psychotic features or bipolar disorder with psychotic features, or history of multiple medication trials. For any kind of severity, we recommend anticipatory guidance for both the patient and anyone available in her support system, her partner, family members, other loved ones, and friends, to start some form of treatment. That can be as simple as recommending or connecting the patient to psychotherapy, to all the way to the level of initiating medication therapy, and checking for underlying medical conditions by ordering a TSH, B12 levels, folate, hemoglobin, and hematocrit, as well as assessing for substance use and medications which may cause or worsen mood and anxiety disorders. I know that's easy to say, and I also recognize that there are numerous barriers to our patients disclosing their mental health symptoms to us. We know that our patients may hide or play down their PPD symptoms at our visits. And a recent study found that almost 21% of new mothers who are experiencing postpartum mood disorders, such as anxiety and depression, did not disclose their symptoms to us, their healthcare providers. And we also have many structural, sociocultural, and individual level barriers to screening for PPD that have been identified. I think many of us are aware that we should also approach EPDS or PHQ-9 scores of 0 with caution if the patient's affect or other factors that we know about that patient suggest otherwise. So it's sometimes helpful to think about where the barriers originate in order to help us think through how we can help our clinic teams and our patients get through these barriers and get help. At the individual level, we know their demographic characteristics, including religion, race, ethnicity, age, socioeconomic status, and sexual orientation, which may be barriers and impact our patients' attitudes, beliefs, behaviors, and their level of knowledge. These can be detrimental on help seeking. The patient may simply have lack of knowledge about the struggle that she's experiencing and that help exists. And there may be time management concerns. And at an interpersonal level, we certainly know that our patients are influenced by their families, their peers, and their patient-provider relationships as well. There may be negative views or low awareness of postpartum depression among family and friends. And healthcare providers may lack warmth or be dismissive of symptoms. At the organizational or institutional level, we know that there are characteristics, regulations, rules, operations, and cultural expectations within institutions. And these could lead to lack of culturally competent care, could lead to lack of language support services, which are a barrier to care, lack of time or privacy with the provider in order to disclose symptoms or discuss symptoms, lack of healthcare accessibility, referral protocols and follow-up capabilities, and inadequate insurance coverage, including inadequate Medicaid coverage, to receive care and continuous care. At the community or structural level, we know that social norms, access to resources, and general healthcare infrastructure can be a giant beast and barrier. And this can lead to unsupportive community norms or cultural models of what maternal roles should look like, as well as shame, embarrassment, and stigma that one is suffering during a time that is supposed to be joyful and natural according to our community and structural level influences. And then at the societal and public policy level, there have been many movements toward positive policies and laws to improve access in healthcare to mental health resources. But there can also be issues with allocation of funding, including inadequate insurance coverage, as well as immigration status and poverty, which impact our patients' ability to have this type of care covered. So wanted to give a case of Lily, who's 24 years old and is attending our OBGYN clinic for her 6-week postpartum visit with her daughter, who is healthy. Lily's on maternity leave from a marketing executive role. Lily has no health conditions and no current medication use. She reports fatigue and low energy, feeling worn out all the time, and complains of headaches, body aches, and nausea and upset stomach for the past 3 weeks. But these symptoms don't appear to be due to an obvious physical cause. Lily also appears to be irritable, but apologizes and states that it's due to lack of sleep and stress. Lily's EPDS score is 8, and she endorses laughing less, feeling jumpy, and experiencing less enjoyment, but you suspect that she may be underreporting her symptoms, and you're concerned that she may be hiding more serious depression symptoms. What kind of communication strategies would we use to build trust with Lily and open up the dialogue? Some strategies for engaging in supportive and culturally appropriate discussions with patients about PPD include normalizing the challenges of the postpartum period and setting non-judgmental tones and open doors for disclosure. Reframing help-seeking as an act of strength and good parenting rather than weakness. Using inclusive and non-stigmatizing language rather than clinical terminology. Offering options and autonomy to avoid prescribing a one-size-fits-all approach. Active listening and non-judgmental listening and using open-ended questions. Bringing in any community-specific resources and culturally appropriate handouts and translated materials as available and needed. Generally acknowledging and respecting others' cultural beliefs. We know that some cultures may view mental health differently or expect women to endure hardship silently. So showing respect without imposing our own cultural beliefs and biases. And then when possible, refer to a mental health professional who shares the patient's background or speaks the patient's language. We know that culturally paralleled and language paralleled care enhances the patient experience and improves communication. One of the strategies that all of us can use is accessing a state or national perinatal psychiatry access program. So a nationally available perinatal psychiatry access program is the Postpartum Support International, or PSI, Perinatal Psychiatric Consult Line. And this is their webpage. Any obstetric care clinician, including OBGYNs, midwives, nurse practitioners, PAs, and family medicine physicians can access this consult line and make a quick appointment to have guidance from a perinatal or reproductive psychiatrist on how to better treat and care for a patient who has perinatal mental health concerns. In addition, the states highlighted in green have existing statewide perinatal psychiatric access programs, and those in blue are emerging. If your state doesn't have a perinatal psychiatric access program and you would like to consult with a perinatal psychiatrist, again, consult PSI. And at the bottom of the page, I also have the PSI Perinatal Psychiatric Consult line that you can call, as above the access program link. If one of your states is highlighted here in green or blue, then you can also get this type of support at the level of your state. Next, I'd like to talk about neuroactive steroid use within interdisciplinary team-based care frameworks. So ACOG clinical practice guidelines recommend that treatment and management of depression and anxiety occur during pregnancy and postpartum. It's recommended that we counsel our patients on the benefits and risk of psychopharmacotherapy for perinatal mental health conditions when clinically indicated, and that we initiate this therapy for perinatal depression or anxiety disorders, or refer patients to appropriate behavioral health resources when indicated, or both. As mentioned, we use validated screening tools to monitor for response to treatment or remission of depressant or anxiety symptoms. And if clinically indicated, up-titrate pharmacotherapy dosage with the goal of remission of depressive and anxiety symptoms. Just as we use validated screening tools to screen for depression and anxiety symptoms, we would use the same validated screening tools to monitor for response to treatment or remission of depression or anxiety symptoms. If it's clinically indicated, we would also up-titrate pharmacotherapy dosage with the goal of remission of depression and anxiety symptoms, ideally before our patients give birth, if they're started on medication prior to giving birth, or during the postpartum period if we are starting treatment during the postpartum period. Treatment for perinatal mood and anxiety disorders needs to be equitably available and accessible to all pregnant and postpartum individuals. And ACOG does not recommend withholding or discontinuing medications for mental health conditions due to pregnancy or lactation status alone. Use perinatal psychiatry access programs as a resource for management and treatment guidance for individuals with mental health conditions when you have questions. And remember that psychotherapy is considered the first-line treatment for mild to moderate perinatal depression. Selective serotonin reuptake inhibitors, or SSRIs, are considered first-line pharmacotherapy for perinatal depression, and serotonin norepinephrine reuptake inhibitors, or SNRIs, are also reasonable alternatives. Pharmacotherapy should be individualized based on prior response to therapy, if applicable, and if there is no pharmacotherapy history, sertraline or escitalopram are reasonable first-line medications. Zuranolone is recommended in the postpartum period, up to 12 months postpartum, for depression that has onset in the third trimester or within 4 weeks postpartum. So to go back to the level of severity of symptoms, conventional evidence-based treatment recommendations for depression, anxiety, and PTSD in the perinatal period are as followed. For mild symptoms, at least psychological interventions, such as therapy, but this could be peer support therapy, online therapies, app-based therapies, as well as adjunct support options like focusing on self-care, focusing on the patient's support system, balancing nutrition, avoidance of substances that can exacerbate mood, sleep hygiene, mindfulness practices, and physical activity, employing psychosocial support strategies, and investigating and managing social stressors, medical and psychiatric comorbidities. For moderate symptoms, all of the interventions that I previously mentioned and other adjunctive or psychosocial support as available, managing medical and psychiatric comorbidities, and starting to consider treatment with SSRIs or SNRIs. For severe symptoms, the patient will need all of the above and will most likely need treatment with an SSRI or SNRI, consideration of medication switch or augmentation if there's no response to the pharmacotherapy started, if that's an SSRI or SNRI. And at the end of the algorithm, consideration of other treatments like an electroconvulsive therapy or ECT when there is suicidality or treatment resistance. So to give you some information on the data that exists for psychotherapy for the treatment of PPD, we know that both cognitive behavioral therapy and interpersonal therapy have strong evidence for changing depression symptoms and severity in the trials that exist. For both cognitive behavioral therapy, or CBT, and interpersonal therapy, or IPT, we know that there have been significant differences or changes in depression symptoms in participants of trials. So data from a meta-analysis of 10 studies with randomized control designs, including over 1,324 participants, examined change in depressive symptoms following psychological interventions for PPD. And the psychological intervention group, or psychotherapy intervention groups, demonstrated lower depressive symptoms than the control groups. This occurred immediately after treatment and was sustained at 6 months of follow-up. There were no significant differences between various types of therapy when comparing CBT, IPT, and counseling. And compared with control, psychological interventions also led to improvements in adjustment to parenthood, marital relationships, social support, stress, and anxiety. We know that monoaminergic oral antidepressants, SSRIs and SNRIs, are the historical standard of care for moderate to severe PPD. We also know that limitations of these therapies include efficacy. The majority of patients on an SSRI or SNRI experience an inadequate response or can have lack of efficacy to these therapies. The onset of action is quite long. With current antidepressants, for those who do respond, it takes up to 6 to 8 weeks to achieve remission. Functioning and quality of life can be limited. We know that improvements in functioning and quality of life tend to lag behind symptomatic relief with SSRIs and SNRIs. And safety and tolerability concerns. Current therapies are associated with significant adverse events that can include weight gain, sexual dysfunction, nausea, anxiety, sleep disruption, all of which can interfere with adherence. Returning to this slide about evidence-based treatment recommendations for depression, anxiety, and PTSD in the peripartum period, we also now know that we have zuranolone, the first FDA-approved medication for postpartum depression treatment. Zuranolone could also be considered in patients with moderate and severe symptomatology, with onset of depressive symptoms in the third trimester out to 4 weeks postpartum. I wanted to talk a little bit about the role of allopregnanolone in the pathophysiology of pregnancy. So what is allopregnanolone? We know that it's a naturally produced steroid and metabolite of progesterone that acts as a positive allosteric modulator on GABA A receptors. It increases GABA A receptor activity, and this results in increased inhibitory activity in the CNS or central nervous system. The hypothesized role of allopregnanolone in postpartum depression is focused on the fact that progesterone and allopregnanolone levels increase during pregnancy, peaking in the third trimester. After giving birth, allopregnanolone levels fall rapidly to pre-pregnancy levels, while the extrasynaptic GABA A receptors that were lost during pregnancy come back, and this causes a neurosteroid withdrawal. These imbalances can lead to increased neuronal excitability and neurosteroid sensitivity, which can trigger PPD symptoms. Administering neurosteroid replacement therapy during the postpartum period rapidly replenishes allopregnanolone levels to third trimester levels, resulting in rapid and effective relief of PPD symptoms. Brexanolone, which has now been discontinued, was an FDA-approved allopregnanolone analog administered via IV infusion over 60 hours for the treatment of PPD. Zuranolone is a synthetic neuroactive steroid that is similar but not identical in structure to allopregnanolone. In 2023, zuranolone became the first orally administered treatment approved for PPD. In this bottom right figure, I'm showing you hormone levels of progesterone and allopregnanolone pre-pregnancy, during pregnancy, peaking just before birth, and then falling again rapidly in the postpartum period. On the x-axis are weeks prior to giving birth, and then days postpartum on the right end of the x-axis. Efficacy of zuranolone on depressive symptoms in patients with PPD has been demonstrated in 2 studies. A phase 3 study called the Skylark study, which included women with severe postpartum depression ages 18 to 45 years old, and within 12 months postpartum were treated with daily oral zuranolone at 50 milligrams daily or placebo for 2 weeks. Zuranolone was associated with a significantly better depression and anxiety outcome compared with placebo, and at day 15, response rates were 57% of the zuranolone group versus 42% of the placebo group. Remission rates were 27% of the zuranolone group versus 17% of the placebo group. In the Robin study, which was also a phase 3 trial, women with severe PPD age 18 to 45 and less than 6 months postpartum were treated with daily oral zuranolone at 40 milligrams per day or placebo for 2 weeks. At days 3 and 15, which was the primary endpoint, and at day 45, there were significantly greater reductions in depression symptoms in the zuranolone group versus the placebo group. There were differences in response and remission rates also, significantly favoring zuranolone, and there were sustained improvements with zuranolone in anxiety symptoms and insomnia. And this is depicted as data from the Skylark study on the left side of the screen in the figure, where day 15, which was the primary endpoint, is in the black box with a significant difference between the zuranolone and placebo groups, sustained out to day 45, which was the key secondary endpoint of the study. There's also a positive effect of zuranolone on anxiety and insomnia in PPD patients. So on the left is a figure showing the proportion of patients achieving concurrent remission in depressive and anxiety symptoms by outcomes and assessment time points. Concurrent scores and remission, with the blue bars depicting placebo participants and the orange bars depicting patients or participants who received zuranolone at days 3, 5, and 45. And as you can see, there are significant improvements at all of those time points. On the right side of the screen are improvement in symptoms of insomnia. And again, the blue line is placebo and the orange line is zuranolone. And the participants who received zuranolone had improvements on their insomnia subscale scores at all of the time points. Zuranolone has a very favorable safety profile. The table on the left shows adverse events with zuranolone at the 50 milligram dose. Participants who received zuranolone had higher rates of somnolence and dizziness, slightly more diarrhea and fatigue, and for most of the other adverse events were comparable to the group who received placebo. In other words, the most common adverse events, or those events that were experienced by greater than or equal to 5% of the group and were greater than placebo in zuranolone-treated patients, were somnolence, dizziness, diarrhea, fatigue, and urinary tract infection. Dose reduction due to an adverse event occurred in 14% of zuranolone-treated patients. The most common adverse events leading to dose reduction in zuranolone-treated patients were somnolence, occurring in 10%, and dizziness, occurring in 6%. Discontinuation due to adverse events was 2% with zuranolone 50 milligrams versus 1% with placebo. The most common adverse event leading to treatment discontinuation in zuranolone-treated patients was somnolence. Therefore, it is recommended that zuranolone be taken at bedtime. Across PPD clinical studies at all doses studied, serious adverse events included a confusional state in 1% of participants. We know that OB/GYN physicians are the top prescribers of zuranolone. We're currently witnessing a system-wide paradigm shift in the way healthcare providers, specifically OB/GYNs, are increasingly screening, diagnosing, and treating PPD. Since FDA approval and commercial launch of zuranolone, over 13,500 women with PPD have been treated with zuranolone. OB/GYNs write 80% of zuranolone prescriptions. A remaining 20% of prescriptions come from a mix of psychiatrists and PCPs. The large majority of the U.S. market now has insurance coverage for zuranolone, and most patients receive zuranolone less than a week after the prescription is submitted, and many receive zuranolone in 1 to 2 days. 80% of patients receive zuranolone as their first new treatment for PPD. Many commercial insurance carriers no longer require prior authorizations or step edits for zuranolone. ACOG has made some specific considerations for zuranolone. The daily recommended dosage is 50 milligrams for 14 days. The dose may be reduced to 40 milligrams if CNS depression effects occur. It can be used alone or as an adjunct to other oral antidepressant therapy like SSRIs or SNRIs. Patients should use effective contraception during the 14-day treatment course and for 1 week after the final dose, as there is the potential to cause fetal harm. And patients should be warned and given precautions about adverse events, including the impaired ability to drive or engage in other potentially hazardous activities. Patients should not drive or engage in activities requiring complete mental alertness until at least 12 hours after each dose for the duration of the full treatment course. Because there are known CNS depressant effects, including somnolence and confusion, other CNS depressing substances should be avoided. And if the patient has suicidal thoughts or behaviors, the clinician should be notified. A common question is, what do we know about breastfeeding while taking zuranolone? We know that zuranolone passes into breast milk, although with a lower relative infant dose than that of other medications, including SSRIs. There are no data on the effects on a breastfed infant and limited data on milk production in relation to zuranolone. A phase 1 study assessed zuranolone transfer into breast milk of non-pregnant lactating adult female participants and a relative infant dose or RID of less than 1%, which is well below the less than 10% relative infant dose threshold considered generally compatible with breastfeeding, was found. In other words, the relative infant dose of less than 1% with zuranolone would be considered compatible with breastfeeding. The National Institute of Child Health and Human Development, or NICHD, says, because of the low amounts of zuranolone in milk, it would not be expected to cause adverse effects in breastfed infants. If zuranolone is required by the mother, it is not a reason to discontinue breastfeeding. Until more data are available, zuranolone should be used with careful infant monitoring for excessive sedation during breastfeeding, especially with higher doses and in newborn and preterm infants. We know that the developmental and health benefits of breastfeeding, as well as the mother's clinical need for zuranolone, should be balanced through a shared decision-making process that also considers any potential adverse effects on the breastfed child from zuranolone or from the underlying maternal condition. How do we get our patients started on zuranolone? There are 3 basic steps which are different from the ordinary prescribing process in the medical record. Step 1, send the prescription with complete insurance information and patient demographics to the correct specialty pharmacy and submit the completed PA. Step 2, alert the patient that they will receive 2 calls from the specialty pharmacy to confirm insurance and contact information and then coordinate shipping. Step 3, zuranolone is shipped and delivered directly to the patient upon insurance approval. Which patients would benefit from zuranolone? Selecting the right antidepressant for patients with PPD based on their individual characteristics, needs, and preferences is an important consideration. For those whom you may more strongly consider an SSRI or SNRI, consider patients who have current moderate or severe symptoms who would prefer to take an SSRI or SNRI. The patient may have presented for treatment during pregnancy, and that was the point at which the SSRI or SNRI was initiated, and then we would definitely consider continuing that. If a patient has had a previous response or especially remission with accepted tolerability, it would be acceptable to consider restarting that SSRI or SNRI. If they have mild to moderate functional impairment, if they're already engaged in psychotherapy and have had a past response or remission with psychotherapy, if they're low risk for suicide, infanticide, or homicide, if they have an active alcohol, opioid, sedative, hypnotic, or anxiolytic use disorder, or the patient prefers not to use effective contraception required of zuranolone treatment and for 7 days following for a total of 21 days. For all of these reasons, it may be more appropriate to consider an SSRI or SNRI. On the other hand, we might consider zuranolone more strongly or as first line for patients with current, moderate, and severe symptoms who prefer zuranolone. If the patient's postpartum and not trying to conceive, if they have not tolerated other antidepressants well, have not responded well to an antidepressant previously during pregnancy or during prior major depressive episodes, or have had a partial response to a maximally dosed antidepressant. You can still use antidepressants as an adjunct and the patient still receives zuranolone. If the patient has moderate or severe functional impairment, if she has challenges to engaging in psychotherapy or has had no response to psychotherapy previously, if she has an elevated risk for suicide, infanticide, or homicide, if there is no active substance use disorder, and if the patient is willing to use effective contraception for 21 days, including the 14-day zuranolone course, as well as the 7 days following that. Other important recommendations for discussion prior to beginning antidepressant medications in general is to discuss with our patients that there's no decision regarding whether to use antidepressants during pregnancy or lactation that is perfect or risk-free, that both medication and non-medication options should be considered, and that we encourage non-medication treatments, including psychotherapy, in addition to medication treatment or as an alternative when clinically appropriate. Risks of antidepressant use during pregnancy include no really consistent or identifiable risk of birth defects when taken in the first trimester, in spite of many studies examining this. The preponderance of evidence does not suggest birth complications, nor do studies suggest long-term neurobehavioral effects on children. There can be transient neonatal symptoms that last from a few hours to a few days after birth. We also know that there are risks of undertreatment or no treatment of depression during pregnancy that include increases in the risk of postpartum depression, birth complications, including low birth weight infants and preterm birth, that under or no treatment can make it harder for moms to care for themselves and their babies, and that there can be impaired bonding between the mother and the baby. If a patient's pregnant, the benefits of taking an antidepressant can outweigh the chance of the concerns that we just discussed, especially when we take the risks of undertreatment or no treatment in mind. If lactating, SSRIs and zuranolone are considered reasonable treatment options during breastfeeding, and the benefits of breastfeeding while taking antidepressants generally outweigh the risks. I want to discuss improving women's access to mental health care through the perinatal collaborative care model for just a moment. So when we think about why our patients are often reluctant to seek treatment for PPD, we know, and we've discussed, the decision about whether to disclose symptoms and whether to seek treatment for PPD can be complex. Women must weigh their perceived need for treatment against the risks and adverse effects that they are exposed to from their family members, from medical providers, from social media, and from other input. They also have to think about effects of their treatment choice on their child, and including exposure to medications while breastfeeding. Other barriers that may reduce patients' likelihood to seek treatment for PPD include accessibility to care, cost of care, the stigma associated with PPD, fears of losing their child to Child Protective Services, time constraints, lack of motivation, lack of support, and difficulty communicating with practitioners. We also know that there are disparities in perinatal care in general, and also for PPD. Individuals who belong to racially minoritized groups, those who live in rural areas, or those who have Medicaid are less likely to receive adequate postpartum care compared with individuals who are non-Hispanic white, those who live in urban areas, or those who have private health insurance. When we look at comparisons of those less likely to receive care components than the reference versus those who are more likely to receive care components than the referent, those with Medicaid compared to private insurance, those in rural versus urban communities, those from racially minoritized groups versus non-Hispanic white, and those with Medicaid in rural settings, other racial and ethnic minority groups, compared with those with private insurance, urban settings, and non-Hispanic white race, also are less likely to receive care components, highlighting many known disparities in care. The benefits of the perinatal collaborative care model include a strong, robust evidence base that integrated behavioral health can improve symptoms of depression and anxiety across diverse settings, across mental health diagnoses and patient populations, as well as medical specialties. When collaborative care models have more recently been applied to obstetric patients during pregnancy and in the postpartum period, the perinatal collaborative care model includes behavioral health specialists and care managers within the obstetric setting. And this is linked to improved patient outcomes, including decreased depressive symptoms by more than 50%, increased screening rates for perinatal depression, increased treatment participation, reduced symptom severity, increased depression remission, reduced severity of post-traumatic stress disorder, increased treatment participation in marginalized perinatal populations, and reduced racial inequities by increasing screening and treatment. Many factors that are improved in collaborative care settings. To give you an example of what a perinatal collaborative care model includes, the patient is at the center. Also included are the OBGYN or other obstetric clinician, a behavioral health care manager, a psychiatric consultant, and the patient. And all of these individuals are in fairly close contact over the perinatal course. The patient is also recognized as an active participant in their own treatment, and they remain in contact with the behavioral health team as well as their OBGYN provider. It's important to utilize shared decision-making to improve patient-centered care. What does shared decision-making involve? It's a process by which clinicians and patients engage in dialogue around available treatment options when there are multiple options to choose from. What do the clinicians provide as part of this model? They educate about PPD, they educate about treatment options that are available, risks and benefits of each treatment option, as well as risk of no treatment versus treatment. OBGYNs can promote autonomy by assuming that individuals desire to be active participants in their care, by encouraging deliberation around treatment options, by promoting the sharing of information. And shared decision-making improves and promotes active collaboration for women when exploring mental health treatment options, the patient's overall understanding of available treatment options, and articulation of informed, confident treatment decisions that align with the patient's needs and values, and recognize that no decision regarding whether to use antidepressants during pregnancy is perfect or risk-free. Must promote an understanding and consideration that both medication and non-medication options exist. For our second final patient clinical presentation, we have Sam, who's 24 years old and visits her obstetrician for routine follow-up at 12 weeks postpartum. Sam is on maternity leave for another 2 to 3 months and is nervous about returning to work as an office manager. As part of her medical history, Sam had an IUD placed at her 6-week postpartum visit and has a history of depression for which she was treated for around a year in her mid-20s. She reports the fluoxetine was moderately helpful for her, but she experienced weight gain and headaches and discontinued the therapy after a few months. Sam reports feeling sad and guilty that she doesn't enjoy time with her baby, crying frequently at home, difficulty sleeping even when the baby is asleep or is cared for by her partner, low mood and guilt along with loss of interest in activities outside of the house, and that her symptoms have been worsening over the last 10 to 12 weeks. Her EPDS score is 18, GAD-7 score 14, and MDQ is 4. Sam has no active suicidal ideation but has considered escaping and often feels hopeless and inadequate in caring for her daughter. Where would you start with treatment for Sam? How would you manage treatment-related adverse events and tolerability to ensure treatment adherence over time? What are the implications for Sam if she's still breastfeeding, depending on the treatment regimen that is selected? How and when should she be reassessed to monitor treatment response, implement dose modifications, revisit psychotherapy and other non-pharmacologic strategies for mental health, and transfer care to other primary care providers? Sam is seemingly an appropriate candidate for zuranolone therapy, especially since fluoxetine was moderately helpful for her, but our goal is achieving symptom remission for Sam. In conclusion, ACOG recommends that all patients get screened for perinatal depression and anxiety at the initial prenatal visit, later in pregnancy, and at postpartum visits. Use a screening tool, become familiar with it, and use it consistently. All psychotropic drugs pose some level of risk during pregnancy or lactation, as does untreated depression and anxiety. The provider or the multidisciplinary team and patient should use shared decision-making to determine if the risk of pharmacotherapy outweigh the benefits of treatment. Zuranolone, a new oral therapy with rapid onset, is the only FDA-approved medication for PPD and recommended by ACOG for the treatment of PPD.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Sage Therapeutics and Biogen. To access all materials for this activity, visit peerview.com/BMZ860.